Uh, I'm just trying to show now how does a normal kidneys look like. So there's early perfusion phase. You can see the abdominal aorta. You can see symmetrical perfusion blush to both the kidneys. And then we have this cortical uptake, very symmetrical uptake. And within a couple of minutes, cortex has everything has filtered out. You can see things in the collecting system. You can see even the ureter intermittently coming in. You can see the bladder filling in. And by this time, most of the contrast has almost completely cleared off. There is a little bit of a radiopharmaceutical in the renal pelvis, which again, you remember renal pelvis can be a bit prominent in some patient. A mild holdup can be seen even physiologically. So that is almost a normal study. If you plot this normal study, we can draw the region of interest, and then we get what we call the relative function. So normally each to the total renal function, which is say is 100, each kidney contribute about 50%. So 47, 53, 48, 52 would be the contribution of each kidney to the total renal function. So that is what we call relative function. And using these, we can plot, and then you get this kind of a curve. So you have this initial perfusion phase, just first minute, followed by this increase rising curve, which is the uptake phase. And this is where you calculate the relative function in this. And then normally after 4 to 5 minutes, normally the curve is going to go down. So that is the clearance phase. So you have this 3 phase of the renogram: perfusion, uptake, and clearance phase. So within 15 to 20 minutes, normally the curve should come down. So that's what the normal renograms curve would look like. And then you get a lot of pathological curves. So normal curve, in this case, we are seeing the curve is reaching up and keep going up. There is no clearance. So that is, and this is the point where you gave the diuretic. Even after the diuretic, the curve is not coming down. So that is what we call obstructed kidney. In this case, you can see the curve going up, but once you give the diuretic, there is sudden drop in the counts, suggesting that whatever that dilatation of the collecting system is not the true obstruction. It is just that dilatation, but it's not complete. The kidney is not completely obstructed. So this is just a baggy system, dilated system, but not obstructed. And sometimes you get what we call the partial obstruction, where the curve starts to come down, but doesn't come down as perceptibly as in this case. So this would be the case of a partial obstruction. People have given us different type, different numbers. Basically, those are not important. Important thing is to remember the pattern. If you have a rising curve, that is an obstructive pattern despite diuretic. If the curve falls down after diuretic, that is normal. If it partially falls down, that is partial obstruction. Is it making sense to everyone? So now, if I just show you some selected image of a patient, so this is the perfusion image. This is the uptake part, so a few uptake part coming into the very delayed part, and say somewhere around here we gave Lasix to the patient, roughly around there. Generally, the Lasix is given about 15 minutes into it, but just say that the Lasix was given around this point in time. So what do you think about looking at these two curves? Which kidney is abnormal and what is the abnormality?
Sir, there is a persistent uptake in the right kidney. This is right-sided obstruction and left side is normal.
Good. So the right-sided is completely obstructed. And if I show you this curve now.
Sir, now there is a partial obstruction of the right side.
Yep.
After Lasix, it's a fall, but not completely fall. And on the left side, it's normal.
And also remember that always that sometimes the visual impression can be very challenging. When you mathematically graph it, you are more
Yes.
confident to call it this is, visually it still looks like, well, significant amount is still there with, yep, but you always get doubling of your visual impression by looking at the plots too. So let me just explain to you the series of images if you are not aware of it. So
Yes.
this top image on here is the what we call, these are the very early images. So just within immediately after injection of the radiopharmaceutical, we are trying to look at the perfusion of both the kidneys.
Okay.
This is the uptake phase. So this was the timings would be here. This is after a minute up to getting into 15-20 minutes. And then after this phase, I'm going to show you what we the post Lasix phase. So you inject furosemide, and then you
Yes.
take further images for another 20 minutes. So you have to go into step by step, looking at the perfusion, then uptake, and then once you have done that, I will move you to the next series of images.
Okay, sir. On the perfusion images of renogram, I showed there is a. It showed that there is a reduced perfusion of the left kidney in
Mhm,
comparison to the right,
mhm,
and no any focal uh, defect is noted on these images.
mhm,
And on the subsequent next further images, you can see uh, there is a focal focal uh, 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 radio sorry uptake areas are noted in uh, right kidneys, and
mhm,
some area in the upper pole of the left kidney. On the subsequent graph, I can see there is uh, uptake and oh, sorry. Um, uh, uh, so there is uptake on right kidney, and which show fallout,
mhm.
and on the left kidney there is plateau of the
Uptake. Okay.
radiotracer, and yes, and which is
So
not
shall we go to the next page and
yes.
see what happens after Lasix?
After
So,
Lasix, the left kidney uh, is still the curve is up, and no fall in the curve, and on the right
mhm.
kidney the curve falls slowly in decline. So on these images, it's likely left-sided PUG obstruction,
Yep,
and
that's
right
what it
is
is. Yep. So look, when it's come to the renal imaging, there are two groups of radiopharmaceuticals that can be used. And then,
okay.
depending on what clinical question is, you select which group of agent you are going to use. So, one is
Yes.
the agent that is taken up and excreted. And okay, so there is a there is a glomerular filtration, and then there is excretion into the collecting system and excretion from the kidney. And in that group, you have two main agents. One is DTPA, other is MAC3. They largely work in the same way. Their uptake efficiency is a little bit different. MAC3 has a relatively better uptake efficiency. So when the renal function is bit impaired or compromised, you get a better renal extraction when you're using an MAC3 rather compared to DTPA, but largely they are one and the same.
Okay.
The other group is where you inject a radiopharmaceutical and that is bound to the cortex. So they get bounded in the proximal tubules and they don't get excreted. And that group is what we call the agent there, the main agent is a DMSA scan. So how do you select? If I'm thinking about obstruction due to any reason,
Yes.
and I'm interested in looking at the uptake and the excretion of the kidney, then
Yes.
I would select one that is being excreted, which is could be either DTPA or MAC3.
Mm,
On images, they both look exactly the same. You cannot make that differentiation.
okay.
If my interest is only to look at the renal function and also to look at any cortical scarring, then I'm not really interested in patient excretory function. Then I would do what
DMSA.
other I
Yes.
would do a DMSA. So
Yes.
where you use DMSA mostly in patients with pyelonephritis. We
Okay.
want to look for a renal scarring.
Okay.
But whenever you have a patient with a renal stone, you have a patient with a ureteric stricture, you have a patient with a congenital POJ obstruction, you are interested in excretion, you use either DTPA or MAC3. And the key to remember is if you have a patient whose renal function is impaired, urea or creatinine is high, or EGFR is a bit impaired, then if you have a choice, use MAC3 because MAC3 would have a better extraction efficiency compared to DTPA. And how do you know that? Because the background soft tissue uptake would be less with a MAC3 than compared with DTPA. Now, so here on the very early images, you can see the abdominal aorta, you can see the bifurcation of the abdominal aorta, you see the perfusion. Now, visually, I agree that you are saying that left kidney has a relatively reduced perfusion compared to the right. But when you look at this very early curve, and this is a perfusion curve, you see that right and the left kidneys are perfusion is almost very
Oh,
symmetrical. That's reduced reduction is basically because of this hydronephrosis in the more medial portion of the kidney is not getting because of the hydronephrosis has a bit of a reduced perfusion. Now, when you come to the uptake, you can make it out. The left kidney is relatively large compared to the right. Right kidney has much better cortical uptake compared to the left kidney. And you can, and then as we go beyond certain minutes, you can see earlier there is no urinary bladder, but faintly you start to see urinary bladder coming in, meaning the excretion has started. And you can see on the right kidney, the contrast has come and is holding into the renal pelvis. The cortical clearance has occurred, still in the collecting system, hasn't completely cleared. The completely normal kidney should clear within 8 to 10 minutes. Okay, so by we are about 1200 seconds, so around 15 minutes, both kidneys haven't cleared completely. That's the point where you give patient a diuretic. If this is a normal study, both kidneys have complete, there is no need to give a diuretic. That's end of the story. You inject a diuretic, and then you put the patient back, and then take images for another 15 to 20 seconds, and you want to see now the excretion from the kidneys. And in this case, if you just keep comparing right and left, you probably can see that right kidney has started to clear, almost clear, doesn't clear very completely, but left kidney, you there's more clearance into the collecting system, comes down into the renal pelvis, and still after 15 minutes, it is not clearing completely. You can plot these on a curve. So once you plot it on the very early curve, you are just seeing both kidneys has a rising pattern and coming to a plateau. And then when you plot a excretory curve, you can see that right kidney's curve is completely coming down, left kidney is almost rising up or is in a plateau, suggesting that there is a decreased excretion from there. So left kidney is obstructed. So there is a left pelvic ureteric junction obstruction there. Sorry, Farid, there's a very long history here, but just read through it.
Okay,
And when you have read it, then let me know.
okay, sir. Okay, sir, I have read it.
So I'm going to show you a DMSA scan.
Yes,
So
sir.
this is the anterior view. This is right
Mhm.
side. This is left side. This is the posterior view, the right here, left here, and then you have some oblique view. So you probably can concentrate on these anterior and posterior views. Um,
Right, sir. So I'm presented with multiple images taken from the DMSA scan of a 1-month-old child. In these images, I can see there is normal uptake is noted in the right kidney. However, on the left kidney, I see the left kidney is not seen in the left renal fossa. In fact, an area of increased uptake, which is conforming to the shape of the kidney, is noted in the left in the left pelvis. And the posterior projections, I can see the similar findings, both kidneys show the normal modulus uptake. Instead, the left kidney, which is a pelvic kidney, shows slightly less uptake at the upper pole. I'm suspicious that it could be scarring, although there is no history of the recurrent urinary tract infections. Considering these images, my diagnosis will be the left-sided pelvic kidney, ectopic kidney.
yeah, so it's an ectopic kidney. Now, just remember that when you have an ectopic kidney, um, the ectopic one would be more anterior if you remember the anatomy. So, and that's why you see more uptake in the
Okay,
pelvic kidney on the anterior view compared to the posterior view.
right, sir.
Uh, and and also remember that some of these kidneys would be rotated, and
Yes,
because
sir.
of the rotation, you can have this asymmetrical uptake in the upper and the lower pole. So to say that the upper pole is scarred is a little bit more challenging in here. And especially as
Mm,
you rightly said, there is no history to point to that. If this patient has some history of UTI, and then you probably would be worried about it. But just because it is not in the normal position, uh, we just have to be a little bit cautious when it comes to the scarring, and talk about it. But you're right to point out that fact that upper pole of the pelvic kidney has a relatively reduced cortical binding compared to the lower pole.
right,
Okay, so
sir.
stay with this, and I would just take you to next case. But before that, remember that with the differential functions, when we do for a DTPA scan or for DMSA scan, we always use the posterior view to calculate the differential function. But when you have an ectopic kidney, and remember
Mhm.
that ectopic kidney would not be in the same location, you take an average of the anterior and posterior view to do the differential function. Otherwise, you would differential function, if you just use the posterior view of this pelvic kidney, would be significantly less if you
Yes,
just
sir.
use this view for calculation. So one of the
Right, sir.
important thing when you have an ectopic kidney, always use anterior and posterior and average out the counts to
Mhm.
do to calculate the relative function.
This is 23-old male patient, 23 months old patient, referred for the DMSA scan after an ultrasound of abdomen. He had vague generalized discomfort in his abdomen for 3 weeks, but otherwise clinically well. So these I'm provided with multiple images of DMSA scan of 23 months old patient. In these images, I can see the uptake is noted. Normal uptake is noted in the bilateral kidneys, which are along with an uptake is noted along in an area along the lower poles seem to be connected, and they are showing the uptake. Um, uh, so. Um, Moreover, I can see there is relatively decreased uptake is noted in the right kidney at the lower pole, and so considering these findings, my differential would be horseshoe kidney with
Mhm.
functioning renal cortex connecting the in the isthmus.
Yeah, so this is a horseshoe, good example of a horseshoe kidney. There is a relatively better uptake in the right moiety compared to the left, and you also see the uptake in the isthmus. Now, this is a very good example of cortical scarring. Now, if you look at the upper pole of the left moiety, can you see, you can see complete absence of the
Yes,
cortical
sir. Contour
outline.
is absent. Yes, sir.
The whole contour is absent. And before you start to call anything scar on DMSA scan, you need to make sure that there is absence or discontinuity of the cortex or defect in the cortex.
Right, sir.
Otherwise, so these areas are hydronephrosis. So these are not cortical
Hmm.
scarring. Remember, you're talking about cortical scarring. So it has to be in the cortex. It cannot be in the
Hmm.
medulla. So, so this patient also has some hydronephrosis, which is out here. But if you look at the upper pole here, even on this anterior view, you see the cortex to be completely missing, much better seen on this posterior view. So there is a scarring, focal cortical scarring involving only the upper pole.
Yes,
And
sir.
does it make sense to everyone? So don't call these areas, which are basically not cortical, which are medullary, to be cortical scarring. Cortical scarring has to be cortical base, and which
Right,
mean
sir.
on DMSA scan there would be reduced uptake and focal absence of the continuity of the cortex.
Right, sir.
Is there any questions on renal that everybody wanted to discuss?